Welcome to today's episode. I'm joined by Brad Hiskins to talk all about nerve pain. This is such an important part of our clinical practice to be able to assess and treat neurological pain. Brad, you've got extensive experience in this region. What are we going to cover today?
Well, it's a very big topic, and there's lots and lots and lots to learn. But we'll try to keep it to an area that we can have an impact on. And I think that's a really important part, is that we really are a very well-suited profession with a good skill set that can make a huge change to particular types of nerve pain. I think that's the most important aspect to get across.
Absolutely. And I think there's a lot of fear due to lack of understanding around this topic. So if we can provide some knowledge and understanding of what it is, how to treat it, and the benefits that we can provide throughout our manual and education, that can be a real key component to effective treatment.
Couldn't agree more, Bo. I think to me, this is what I tell my students or people I'm mentoring, is that anyone that walks through the door, anyone, doesn't matter who it is, they're going to have a component of nerve symptoms. And that component might be 1 or 2%, but it could be 100%. I think the important thing to understand is to be able to recognize that, acknowledge it, assess for it, and then you can provide a treatment protocol that's going to be a lot more objective. I know there is a lot of fear, and it's understandable, is that people see nerves and they panic. But when you understand how nerves work and how the nervous system works, the more you understand that, the less you are scared of. It's like any topic, really. And this all come about for me. I was at the Institute of Sport, and I had one of those weeks when a lot of the athletes were away, so you didn't have to treat all day long. And I picked up Butler's book. Once I started reading that, I got halfway through it and thought, why did we not learn this? Why did we not learn this? It wasn't one of those add-on sort of complementary topics. It annoyed me. I thought, this is ridiculous. Not knowing this makes us less objective in our decision making. We don't know when to refer. We don't know how to assess. We could be doing something which is completely contraindicated just because of our lack of knowledge on this area. So, yeah, from then on, I learned a lot. And of course, I spent probably 25 years now sort of teaching it. And for the people that don't know, when we first wrote the competencies, which is a long time ago now, is that nerve assessment and treatment was agreed upon in the Sydney meetings to be part of the package, the original competency. We all agreed it was really important. What we didn't think about was the fact that we just didn't have enough people to teach it. So it sort of fell out of the competency, if you like. And you only have to look now, is that for those that did follow the new competencies that are going to be written, nerve or pain science, if you like, which is all about nerves, of course, is now a fundamental new part of the package. It's been acknowledged that it is super important. So I think over time, we're slowly getting through to all those people that are authorities within the profession. That's how important it is to understand the basics of nerves.
Yeah, absolutely. That's the fundamentals when we look at any sensory input, even those residual symptoms that don't tend to go away, and we sort of banging our heads against the wall thinking, what could it possibly be? We've got to consider the nervous system and the influences from not only the physical body, but then emotions and beliefs and a range of other factors as far as our psychosocial understanding of nerves, which is it's significant, and it's such a huge component to the way that we assess and treat.
Yeah, and look, when I say everyone has a nerve component, it's not just the physical nerve I'm talking about. It's the nervous system. You've got the psychological component, the motor sensory component, the autonomic component, if you like. Then they're all combined as one. You can't separate the two. So if someone comes in with a musculoskeletal pain, if that person is in a state of stress, anxiety, whatever the case may be, it'll heighten it. So hence, that state of anxiety is a component within that person's presenting symptoms. Now, how you identify that within the history taking and subjective assessment is a little bit difficult, especially for a young therapist, because it's hard to say, are you stressed? Are you anxious? Because it's a difficult question to ask. So you have to learn ways to do that doesn't create any further stress or anxiety. But you'll recognize it. You'll start to recognize it in people and think, this person really does have a big anxiety component, a psychomotor component that will be, it'll exacerbate the symptoms they're presenting with. So unless you acknowledge and try in some way to help that person deal with that component, I'm not saying become a psychologist, I'm saying recognize it so you can refer them off to someone who can help. If you don't understand that part, then you'll be missing a big box that needs to be ticked. And all the way through to, you've got your nasty parts of your assessment, which it can be upper motor neuron sort of conditions like your multiple sclerosis and so on. It's, again, you don't need to be an expert in it. You just have to understand what the symptoms are so you can refer those people off. And I've had a long career, so I've seen a lot of people, and I'm not sure if I'm fortunate or unfortunate in that having this knowledge, I have recognised quite a few of my patients that have had some pretty nasty red flag signs. I'm glad I did, because I was able to refer them off quickly. I'm not sure who was worse off, me or them. I went home trembling, thinking, I think I've just sent someone off who's got MS. But I was very, very happy when I thought about thinking, at least I had the knowledge to recognise the symptoms and I knew the protocol. So I've got to get this person off to the right person so they can be diagnosed properly and then put on a proper treatment program. It's important to understand that component. We might not ever use it, but gee whiz, it's important to know. But then it comes back to stuff that we can treat. Just understanding anxiety. If you're looking at it from a basic massage therapy point of view, if you understand the 10, 12 psychomotor components to presentations to anxiety, you can recognize and you think, well, the best thing for me to do here with your massage skills and knowing the research to this is that on average, from a relaxation massage, you get a 30% decrease in cortisol levels. That's enormous. That's enormous. So you can have a huge benefit for the anxiety component, that nerve component. I suppose a lot of people don't consider that as a nerve-related condition, but it is. Then you get the stuff that we can actually treat, which is the more the peripheral nervous system and sometimes the central nervous system, which is more what we're talking about today.
Yeah, and that's really what's a great point there is we need to recognize the more serious upper motor neuron diseases or pathologies, but we can affect a lot of the stresses that people feel and then have an effect on those peripheral disorders, your radiculopathies and peripheral nerve compressions, which I'm sure you'll elaborate on as we go through this presentation. Yeah,
absolutely. So I think that when people start to learn about this stuff, it's a bit daunting like anything because you don't know where to start. And as my mother-in-law keeps saying, on any big topic, how do you eat an elephant? And her answer is one bite at a time. So, but where do you start? How do you start the learning process? And that's what this is an old PowerPoint presentation. I probably made it 10, 12 years ago. It hasn't changed too much. And I think it's just look, if people want this, that they can by all means have it. It's just the way I used to present this topic when I was running around the countryside doing presentations. And to me, it's a summary for people to start the learning process. And I think the summary really starts in, you got to understand the basic anatomy. And I'm not going to go into the upper motor neuron stuff. That's for someone else to teach. But to me, the basic anatomy, which isn't that difficult. Don't worry, the brain stuff, yeah, that's crazy difficult. It's hard enough to say the words, let alone spell them or understand them. But for us and what we do clinically, we don't really know. It'd be nice to know that stuff, but it's not an absolute must-know for the sort of presentations that we'll be treating. So should I just get into the anatomy?
Yeah, we'll get started.
Right. So I think as an awareness, like you've got to be aware of nerve pain, number one. If you're not aware of it, then you've got no idea what's going on. And you have to acknowledge that nerve pain exists. So that's what this slide's saying. You need to just be aware that nerve pain exists. And nerve pain can be anything from an ache in a joint. People that present with, they say, I think I've got arthritis. They go off and have their blood tests and their scans come back completely negative. You put them through an upper limb tension test and it reproduces their joint pain. So nerve pain can present as just about anything. It's crazy. It can mimic stuff. It can be all different types of paresthesias. And paresthesia, the way I used to teach it, was, excuse French, weird-ass pain. Because that's the way your patients would present. I've got this weird-ass pain in my, I can't describe it. Anyone who has suffered through nerve pain would understand. It's really difficult to define. It's really difficult to say, it feels like, no, I can't tell you. You do typical stuff like your pins and needles and that sort of stuff, which is, or the anesthesias or the numbness. They're pretty easily relatable back to nerve-based pain. So it's just the understanding that nerve pain does exist and it comes in all types of forms. It's not just the one thing. It's not just pins and needles. It's all sorts of pain. I think that's the first thing. The next thing with nerve pain is understanding the basic anatomy and physiology, which we'll get into. So basically the anatomy is, for us, what we need to know is the central nervous system and the peripheral nervous system. And we'll expand on that. Then understand the pathological knowledge. Again, we're not going to go into some of what we call the intraneural or the upper motor neuron stuff, which is more for your specialists. But it's good to have a knowledge on those, that they exist and what the red flags are. And then what's important is subjective assessment. So when someone presents to you with any given type of pain, I've got lateral calf pain, so don't just jump, all right, musculoskeletal condition. You must think, is there a component of nerve here? At least look for it, all right? You can look for it and go, don't think there is. I've done my objective assessment, don't think there is. At least you've looked for it and counted it in or out. Then, of course, your subjective assessment is your things like your straight leg raise, your upper limb tension tests. So what they're for is if you in a subjective assessment think, I think there's a nerve component here, those tests are there for you to confirm or deny that belief. So if you think, I think there is, go through the test and think, actually, it's not positive in any way, shape or form. I don't think there is a nerve component, or it's minor to what I thought it was. Right, so that's how you use your subjective and objective tests. Yeah? And then, of course, you've got all your treatment and referral options. And we've already got all the treatment options. We just need to know when they're indicated and how to use them. So that's, in a nutshell, lesson over. All right, moving on. So this is the important part, is that nerves not only transmit the perception of pain, can also be the source of pain. So nerves have nerves attached to them called nervo-nervosum. So if there's something going wrong with that nerve, then that information will be fed back to the central nervous system, your spinal cord. And if necessary, spinal cord will go, too much for us, we need to get the brain's help here. Sends messages to the brain going, pain, pain, pain. Then we make a conscious decision rather than a reflex one. So nervo-nervosum means that nerves can be actually a source of pain, just not transmit pain. And for us, with what we're talking about today, with mostly the peripheral nervous system, if nerves can be compressed, stretched, tethered or adhered, and it can be disease states. All right. So you think about when you sleep with your arm up like this, and you're potentially just compressing the nerve. When we talk nerve, we're talking wherever the nerves run, we tend to have arteries running with them. So that's why it's called the Neurovascular Bundle. And they run together, one, because nerves need a lot of oxygen. It comes from the bloodstream. But not only that, is that they tend to run in the least vulnerable positions in our bodies. So obviously nerves and arteries are incredibly important. That's why you don't get too many on the surface of your skin, let's say, where you've got plenty of veins on the surface. They're not as important. So nerves and arteries tend to run together. So in this scenario, we're potentially compressing the nerve and the artery, hence neurovascular compression, right? So you can have compression conditions where you compression, like in this scenario, let's say underneath the coracoid process. So you get compression, you wake up with a dead arm. All right, so that's just an acute thing that goes on in a few minutes. You can have overstretched. And overstretched is like the classic examples when you've got a bunch of country blokes that go home for Christmas and all your uncles go, let's have a game of cricket. We haven't played since last Christmas. And of course, being country boys, we're all the best cricketers ever. And when you bowl, even if it's to your 6-year-old cousin, that does not matter. You must bowl as fast as humanly possible and take their head off, because we're stupid males. Forgive us. So when you come in and bowl for the first time and you see your 70-year-old uncle come in, like Dennis Lilly, bowls, screams with pain, grabs hold of his thumb. Oh, what the hell just happened? So you've got someone who hasn't got that range of motion for a year. Not only does he go through a bowling range of motion for the first time in a long time, but at such a severe pace, because you're bowling a bouncer to your 6-year-old cousin and try to kill him. All those things added up, you've got a median nerve, which is on this ridiculous amount of acute, abrupt stretch. And of course, you then get pain through the periphery where the median nerve runs. So again, if you want to be a smart aleck, you can learn that sort of stuff. Go home, watch your silly uncle bowl 100 miles an hour when he complains about his thumbs, or you can say, that's because your median nerve's irritated, uncle. And they'll look at you and go away. All right, so you can be stretched, and that's an acute episode of stretching. Adhered, so you can get a classic adherence. Let's say you sprain your lateral ankle. The ligaments start to come good, but at about 3 weeks mark, you can start to get pain around your fibular head, or maybe pain a little bit further up on the outside of your calf. Now, a lot of people say there might be a perineal involvement, right? But you've got to consider in this case the common perineal nerve, because portions of common perineal nerve can go straight over top of that healing ligament. As the ligament heals, then the nerve can get caught up in that healing scar. Instead of sliding, as the nerves like to do, it can get caught and adhered. So when they don't slide well, they'll get the shits, and they'll start to create pain along that line of that nerve. And why 3 weeks? Because at about that 3-week mark, healing scar goes from collagen 3, which is a really well-hydrated mobile collagen, and start to dehydrate and shrink to a collagen 1, right? So when it dehydrates and shrinks, if the nerve's caught in that healing scar, it won't slide as well. That's why about that 3-week mark, we can start to see pain at the fibular head, because the common perineal nerve has a little attachment to the fibular head. All right. So that's where, as an example, a nerve adherence can occur. So straight away, for those people that have seen a few lateral ankle sprains, you might think, hey, wow, I saw that in my patient. Wow, maybe that's what I should have been looking for, is that adherence of the nerve within a scar. All right, and there's plenty of disease states. We won't talk about them today, but it'll go forever. How are we going? Too slow, too fast? Just right. Perfect. Exactly. All right, so what's the gross anatomy? So you split it into the central nervous system and the peripheral nervous system. All right, so the central nervous system is the brain and the spinal cord. The peripheral nervous system is outside the spinal cord. All right. They're two different anatomies. Although they're connected, they're two different anatomies. All right, so what they're fed with, central nervous system with cerebrospinal fluid, is different to peripheral nerves. The spinal cord itself has one incredibly strong piece of connective tissue called your dura. Incredibly strong. It's longitudinal in its alignment. It's incredibly strong. And two really weak bits of connective tissue. Your arachnoid, for instance, which is like a spider web, but it's more for filtration, where your dura is more for the rigidity of the system. It protects it. Your peripheral nervous system has 3 connective tissue layers that are similar, but not similar in their rigidity and their strength. There's one stronger than the other, but we won't get into the technical side of things. So you're going to have an understanding of that the central nervous system anatomy and the peripheral nervous system anatomy is different, all right? And it changes from central to periphery at the spinal nerve, right? So as the nerve exits from the central nervous system, and that spinal nerve occurs at about that foramen minor, which is that hole where it traverses through, and the facet joints are involved. From the spinal nerve out becomes your peripheral nervous system. And that becomes really, really important anatomy for all sorts of reasons, because the mechanical interface, which is all the structures that surround a nerve, we treat the mechanical interface. We don't treat the nerve. So we've got to understand the mechanical interface. But also with the central nervous system and peripheral nervous system, and you'll see this little map. Most people have got it stuck on their wall, but don't know why it's stuck in the wall. We'll bring it up in a minute. Is you can use these maps to understand where the damage is, or not the damage, but the irritability, the compromise is within the nervous system. So it's the dermatome map. So derm, I mean, two Latin words, derm meaning skin, tome meaning pattern. So those dermatomes are skin patterns. So the damage is at the nerve root or inside, so where a disc or a facet joint might irritate a nerve, then you'll see a particular pattern. But if the damage is done outside of that, you'll see a completely different pattern. Well, not completely different, but substantial enough to be able to differentiate. So from just that, having that knowledge and understand that poster that's on your wall, the person will go, hold on, that's my pain there. And you think, oh, that's an L4. That's L4, which means it's a central, so it's probably a disc or a foraminal thing. Or he might put their finger to something else. You think, oh, actually, that's an L5S1. So that's a peripheral nerve. So hence the compression might be through the gluteal region or through the hamstring region or somewhere else, which we can treat with a lot more efficacy, right? So just understanding the anatomy, which is the central and the peripheral, where it transitions at that spinal nerve, straight away, you can get a whole lot of knowledge whether you're dealing with something which is like a disc bulge or a facet joint or a foraminal or a peripheral nerve. And that will substantially change your potential referral or your treatment protocol. All making sense?
Very good.
I haven't done this one for a little while, so I'm just like hitting.
But I think that's a great point. Using the combination of your symptoms with patient symptoms with, looking at something like a poster and identifying, is it a central problem or is it a peripheral problem? And then directing your treatment based upon that.
Yeah, use that map. And don't pretend to try and memorize that map. I've been looking at that damn thing for 25, 30 years, and I still get stuck. So often I'll say, look, this is me forgetting in clinic, and I'll go, Bo, look, have a look at this map for me, mate, and tell you where your pain is. And I'll go, whew. And I'll go, that one, yeah, I thought it was an L4, I got it right. So they can use it to say, that's my pattern. Just like let's say a trigger point poster. And people will look and go, that's my pattern of pain right there, and you go, right, upper trapezius trigger point. Right. So you can identify that using those maps. I'll just skip through a couple of these, Bo, because that's just the central nervous system there. Old gory picture. I hope people didn't faint. I'll just spew up their dinner. And this is an example of your peripheral nervous system. And looks scary there, lots of nerves, hey? But they're pretty simple. They're not too difficult to understand. And I've just got a couple of highlighted there, your ulnar nerve and your median nerve. And they're probably a little bit displaced in this cadaver, but I'm not sure if anyone has seen, again, having an understanding of where they lie can completely change how you treat or where you treat. I'm not sure if anyone's seen the Theragun ads. They're bloody everywhere, all over the internet and on telly. And I saw a lady with a Theragun, and she's got her arm up and she's Theragunning this part of her arm. I thought, whoa, geez, be careful, because you've got along just underneath your bicep here runs your median and ulnar nerve, and you can flick over them, but be really careful when you do so. And this is where the anatomy gets even more important. One, you know that there's two nerves running there, right? But two, why are they so vulnerable here? Whereas your ulnar nerve through the ulnar groove, you can not belt on it, but you can tap on it with very little damage. Reason being is that the amount of connective tissue around your ulnar nerve here is 8 times that of 4 centimeters above. Right, so your body's got protective mechanisms around this area because it's so exposed, because you tap it all the time. And of course, truckie's elbow, when someone, your truckie's sitting like this all day, like driving along, comes in with some type of paresthesias in this portion of their hand, which is the ulnar portion of their hand. The reason being is they're sitting like belting along on with their ulnar nerve sitting on the door frame of their truck for 25 hours at a time. And of course, it's irritating the ulnar nerve. So again, there's another little quick one for you. Truckie's elbow, compression and irritation of the ulnar nerve. But importantly here, because there's 8 times less connective tissue, it means that the nerve component of the peripheral nerve, because the nerve is made up of connective tissue layers and the actual nerve tissue itself. So when you've got less connective tissue layers, like in this area here, all right, one, it moves better, which is great for the biomechanics, and nerves need to move, but it's exposed because of the less connective tissue. So when I saw that lady belching along with a Theragun, I thought, whoa, get rid of her for some paresthesias. That's going to ache a bit later on. All right, so that's why you just don't belt your fingers up through this region. Don't think, oh, what's that little flicky thing there? It's a nerve. Be careful. All right. Obviously, your body's made the decision. We don't need a lot of protection here because our arm's by our side most of the day. Probably what our anatomy didn't think about was us crazy mongrels playing sport and tackling people and having elbows and heads hit that area and creating little nerve issues. All right, so that picture there is just an example of a couple of nerves in the periphery, the medial ulnar nerve. And just as I said before, it's made up of 2 tissues: the conducting tissue, which is the nerve tissues, as we have here, and then the supporting and the connective tissues. And there's 3 main layers: endoneurium, epineurium, and perineurium. There's an outer layer called your mesoneurium, which is not actually a connective tissue as such. It's a little bit different and not really considered a part of the nerve. It more surrounds the nerve. All right. Gets a little bit technical, but you can all go and read about that. It's very exciting. And the spinal. So when we talk about, obviously this is the spinal cord, and then we've got your ventral and dorsal roots, and then they combine around this spinal nerve, and it's around this spinal nerve area where, so this portion here would be peripheral, and this portion here would be central, right? So this is central nerve stuff, this is peripheral nerve stuff. And if the irritation occurs around here, you'll get a different pattern of pain. They're embryonic type patterns, if you want to get into that side of it, right? Because you look at the pattern and think that makes no sense anatomically. But then embryonically, when our limbs grow, they just don't butt out. They actually torque out. Hence why, like the L2, 3, 4 patterns wrap around your leg. Right? So these will give you those embryonic dermatomal patterns. Cutaneous nerve distribution, which is what's the peripheral nerve distribution is called. They more or less run on the anatomy. So wherever the anatomy of that nerve goes, that's where you potentially get pain. And that's why on that map, which we'll see soon, that's why they differentiate between the 2. All right. Stop me, Bo, if you want me to.
That's really good. I think just making people aware that obviously all of that sensory information will come through that dorsal part of that nerve into the dorsal horn, whereas all output or efferent information will go through that ventral root.
Yeah, so afferent information is that comes from the periphery into, so it's like the info that the nerves have collected, it's taken it back to the central nervous system, and then a decision is made here, and then it goes back through the efferent system and a response is had. Yeah, and if there's a lot of information or the types of information that reaches comes via the dorsal root, then sometimes it gets sent up to the brain, so we make a conscious decision.
Yeah, so the grey matter is all interneurons, and then you've got the white matter, which is the highways straight up to the brain. Yeah,
that's right. If you want to get into that anatomy, it's crazy difficult, but you can understand just the basics between white and grey matter. Yeah. And again, just another depiction of that spinal nerve area. Again, there's a dorsal root, so information comes in here, gets processed, and then a response comes out this way. That's about a 20,000 page book in one sentence. All right, so this is a depiction of some of the issues with the central nervous system. So you can see, obviously, the facet becomes really important, and the facet can have all sorts of issues. You can have osteophytes and swelling and degeneration, which may impact on the nerve root. That's one. And the other one, the main one, is obviously your disc. So you can have disc issues which can compress on your nerve root. And remember, with disc issues, just because you have a disc bulge, it doesn't have to have a nerve component, right? A disc bulge is completely normal. I don't want to know how many I've got. Again, an MRI showing that I've got disc bulge means nothing because that's completely normal for someone my age, right? It only becomes an issue for your nervous system when that disc bulges enough to compress that nerve, all right? Fundamentally, that's the way it goes. All right? Question?
Well, yeah, that's really interesting when you look at it like that as well, because there can be that mechanical compression. And I think because there's so much fear around radiculopathies or nerve compression at the spine, but sometimes it can be a chemical irritation as well, where sensitizing chemicals can affect that nerve. And you mentioned the nerve nervosa before, where that's why, ridiculous symptoms can be a lot worse in the short term, but then they can settle down as the inflammatory and sensitization component settles down, which is, yeah, it's important to consider that to help to reduce some fear in patients as well.
Yeah, that's why the more we know, the more we can explain to the patient this is what's going on. Right? And you don't have to pretend like you're an expert. Like say, to my knowledge, this is what I understand about the nervous system. If you want to know more, I suggest you get a referral to whoever. But again, the more we know and we can portray that to the patient, the less fear they'll have. I mean, disc bulges, like a lot of people go, a disc bulge has got everything to do with nerves, but that's wrong. It's just another mechanical interface to the nervous system. We do tend to associate those through all sorts of social means that have been around historically for a long period of time. You can have a massive disc bulge and no nerve component at all. You can have and again, a disc can bulge without the disc being degenerative or even damaged. It's just bulging out. It's only when you start to get where the outside of the disc, say, splits, so you have a nucleus pulposus popping out, and then you get a whole lot of pain because the outside, the annulus of the disc is highly innervated. So any damage to the outside of the disc, you'll have enormous amounts. Well, you potentially can have enormous amounts of pain. Doesn't mean you got any nerve pain because you might not still be compressing on that nerve. So when you get back pain and nerve pain, it means it's popped out enough to press on the nerve, in the simple terms. Yeah. And that can, so you've got the disc, your facets, and that foramen minor are probably the three main things that can cause that biomechanical compression of the nerve system. And the swelling, you can just have a lot of swelling that compress on the nerve, right? So this little area here with a whole lot of nerves combining, sorry for those people that already know this stuff reasonably well, that's called a plexus. And a plexus, so we've got a number of plexuses throughout the nervous system, and all the plexuses is a number of nerves coming together. So let's say your cervical plexus, when you got from a little bit of C3, but C4, 5, 6, 7, C8 is actually a nerve, even T1, they all combine into a plexus. So all the nerves combine and then pop out the other side as peripheral nerves. Right? The reason for it, to summarize, if that didn't occur, let's say, and we had C5 nerve root that became a peripheral nerve, right? So it becomes a sensory and motor component to a number of areas and muscles. If that C5 was damaged and that nerve, let's say, died, everything that was sensory and motor to that would be gone. You'd lose it all. All right. And if I did that motion and the C5 nerve root was tugged on, all that load would go to that one portion at C5. But when you've got a plexus where all the nerves combine, and it's a very strong area, if you want to do this, that load is distributed throughout all the nerves through the plexus. So it's a protective mechanism. Okay. So if C5 is not functioning as well as what it can, then C4 and C6 will all kick in and contribute more. Right.
So that's why we have paresthesias more commonly than anesthesias.
Oh, I don't know. That's a really good question. No, I'd have to go and search that one, mate. Sorry.
Yeah, but because there's going to be crossover of those different dermatomes, right?
You mean, sorry, I get your question now. So you're saying like anesthesia when the whole nerve's dead, if you like.
Yeah,
that's right. So that's where, like right here, I mean, all that tissue where you press on, that's just in front of your scalene's medius. I mean, that's your brachial plexus. You can generally poke and prod through there. You have to be a bit careful, obviously. Again, this is good it's a good understanding of the importance of nerve anatomy. If you understand where your brachial plexus is, you're not going to smash through it thinking it's your scalenes. So you've got to be able to palpatory identify that. So I can poke through that area and it's relatively robust, right? So that's the importance of a plexus, and that's what it is. So you've got your cervical plexus and lumbar plexus, sacral plexus. Interestingly, the thoracic spine does not have a plexus. I'm sure you remember this, Bo, because I remember thinking if you get this question wrong, I was going to throw a bucket of water over you. So why doesn't the thoracic spine have a plexus? Because we have ribs. So the ribs protect each individual nerve. However, if you do have damage to one of those nerves, then that whole area will suffer quite significantly. I've had that happen to me. And now I've just got a numbness through one of my ribs, and that intercostal is pretty much atrophied to the point where it is no more. Can't feel anything. All right, so that's where the thoracic spine doesn't have a plexus, and that's the reason why. All right. So that's the plexus scenario. I love this little photo. I think this defines the mechanical interface really well for femoral nerve. And it's the mechanical interface that I can't express enough how important it is to understand the mechanical interface. You've just got to, if you don't understand the mechanical interface, which is the structures that surround each individual peripheral nerve, then you can't treat that nerve. Because we don't treat the nerve, we treat the mechanical interface, right? So as an example here, you can see the femoral nerve. Right? And you can see how the femoral nerve comes from L2, 3, and 4. So any damage to L2, 3, and 4 can give femoral nerve issues anywhere along the femoral nerve, right? The next mechanical, so the mechanical interface is those discs and fora minor and facet joints. Then as that nerve comes out of the plexus and then starts to become a single nerve like it is here, the next mechanical interface is in between your iliacus and your psoas, right? And it can be a very thick septum in between those two. So the femoral nerve may, and it can pop out right through the fibers of the psoas. So it's, the sciatic nerve is not the only nerve that can run through a muscle, which most people would believe, unfortunately. So the femoral nerve can pop out between those two, right? And that septum can be very, very thick if that side is loaded more than the other, let's say. So the thicker the septum, the less that nerve potentially can slide, right? So having an understanding of that, that's where the nerve traverses through, that's the mechanical interface through that area, means that if someone has femoral nerve symptoms and signs, straight away you can treat around L2, 3, and 4. The next mechanical interface is to treat in and around iliacus and psoas in the septum. The next mechanical interface, not depicted well here, is through your triangle, your femoral triangle, right? It runs right through the middle of it. So just on the inside of it is your femoral artery. Okay, so if you put your hand on the femoral artery and go just lateral, and that little tissue, that little ball of tissue running longitudinally is your femoral artery. Right? So again, if you know the anatomy, you can easily palpate that stuff and understand them. Right? Now, there is palpatory signs to nerves. You can often roll over a nerve and don't get any pain whatsoever. But you can roll over a nerve and have a lot of sensitivity where the person will jump. And if you compare that to the other side with much reduced symptoms, you think, well, wow, this nerve really is irritated. Okay, so this is the next mechanical interface. So if you understand this femoral triangle here, you can understand the tissues you can potentially treat and allow this nerve to move and slide without restriction. So we've got L2, 3, 4, the septum and psoas and iliacus, the femoral triangle. We've already got a whole bunch of areas that we have a great skill set to treat. Our hands-on skills are better than the other professions because this is what we do. This is how we're trained, what we do all day long. So if someone's got some type of adhesion or tethering of the femoral nerve through this area, we're the people that can treat it well. We have the hand skills to do this. Yeah. And I think that's where I get a little bit frustrated when I heard we don't treat nerve issues. And I think, well, that's crazy because we're the ones with the best skill set to treat this stuff. By all means, have a good team around you, good sports doc or sports physician, your referral patients, your osteo, your chiro, your physio, have them around you. But I guarantee once you get to know these people well, they'll acknowledge that you've got the best skills to treat this area, right? Got your osteos and chiros and physios that might want to treat the joining complex of your back better than what we can, but we're going to have the best skills to treat this myofascial component, yeah? From there, the femoral nerve, it splits. It's got the one main nerve that goes through your quad, but then it splits, and it's not depicted here really well at all. Actually, I don't think it's depicted at all. Is that the longest single nerve in the body runs off in this direction underneath your sartorius, called your saphenous nerve. All right. So as an example of the mechanical interface and getting to know it, this is a great little picture. Great little picture, understand it. And as you see over here, you've got bones, joints, fascia, muscle, ligaments, tendons, connective tissue. They're all the mechanical interface to peripheral nerves. All right. Now, a lot of people go, oh, there's a lot of bloody nerves here. But you can simplify it. There's three main nerves in your lower limb. Your femoral nerve, your rotator nerve, which is not really depicted that well here, and your sciatic nerve. So there's only three. They then split and become other nerves, but there's only three to begin with. All right, so it's not as difficult as what people assume. A lot of these little smaller nerves, once you've learned the major ones and you're comfortable with that, then you can start learning the minor ones. Right? In the lower body, I would plead with people to understand the colonial nerve. Plead with people. Because to me, and a lot of people I'm speaking to, a lot of sports physicians especially, I have a strong belief that there's probably the most undiagnosed nerve irritation in the body. We get so much pain around the lateral gluteal region into the groin, down the outside of our thigh, which is the colonial nerve distribution. And the colonial nerve comes from T11, T12, L1 area. And around that T11, T12, L1, which is the area of our body where we've got big changes in our facet joint orientation. So within two joints, you can move in every direction. Hence, it's called often the universal joint. So when a joint or an area moves a lot more than others, then it potentially has more likelihood of damage, and it's the colonial nerve that can be damaged. You understand that little nerve, where it traverses, then you can make great changes with soft tissue work. Huge changes. Cupping over the iliac crest for colonial nerve irritation has a great impact. In fact, such a good impact that the first few times I did it, I shook my head thinking, this is ridiculous, this can't work this well. But if you understand the anatomy and what you're trying to achieve and the colonial nerve, then yeah, you can make big changes. So, oh, Midgie's back, sorry. The bigger nerves, definitely learn them first, but there's certain minor nerves like the colonial nerve, which I'd say go and learn that one because it is so significant in what we see in lower back pain, hip pain on a daily basis.
So we'll just talk about that a little bit more for people that may not be that familiar with it. But that, as you said, it's from that sort of lower thoracic, upper lumbar, but it will pierce through that thoracolumbar fascia. And as we know,
yep.
Yeah, the fascia is highly innervated. When you look at non-specific low back pain, and you can't really identify a specific cause, and they've got these symptoms of irritation and pain into that posterior hip gluteal region, it often gets misdiagnosed as a piriformis syndrome or a sacroiliac joint disorder. But what's really interesting is the innervation through those iliolumbar ligaments and that lumbosacral fascia, which could be due to that colonial nerve.
Yeah, and again, as we started, if you don't have an awareness that nerves can cause pain, then you're not going to look for it. And you might be completely missing. Or you might have a good effect because you actually might bash your way through your lumbar spine, and just through a bit of sheer luck, you might help mobilize it and think, oh, it was the quadratus lumborum. But again, I'd say, no, it's a little bit naive or ignorant. And I don't mean that with any offense, because the profession hasn't done well enough to teach us this stuff. So, but again, if you understand that nerves can be the source of pain, then you'll think, well, hold on here. I need to focus on a few different things. I need to at least consider that nerve can be a component or the component I'm looking at. the component. So that, I mean, as you said, the nerve travels from that T11-12L1 and then travels through your quadrant lumborum area and all that associated fascia, and then it crosses your iliac crest on 3 portions, right? And the middle portion actually runs through a connective tissue canal. And it's that portion where most of the research suggests that is the portion which is most likely to be compressed or tethered. Yeah. You can run your hand across the iliac crest on the contralateral side. You feel for the thickening of the tissue, right? And the mobility of the tissue. The patient feels for their sensation, right? Then you go to the side, which is their painful side. Run your hand across the iliac crest, right? Knowing you can have a look where the colonial nerve runs, it's like 4 centimeters, 8 centimeters away from L5S1. You'll feel them. You feel a little, like it feels like a bit of cotton. You run across them. You go to the painful side, you'll often flip across that nerve and the person will jump and hit the roof. And it'll just minor pressure or the same pressure as the other side, right? So you think that nerve is really irritated. Then you often get to that connective tissue tunnel and often think, wow, this is 2 or 3 times the size and the thickening as the contralateral side. So it's obviously had a lot of load through that area. That connective tissue is then built up to protect it, but got to the point where there's too much built up and that nerve now doesn't slide well. So you think about that area, we can muck around with our fingers and so on, but think about what cupping can do. You can draw that tissue away from the nerve and mobilize it, move it and so on, create a lot more mobility, right? Then you can do your other hands-on soft tissue work. And then if you're understanding on where that nerve traverses, you can actually then mobilize that nerve after you've treated that mechanical interface, right? Make that mechanical interface mobile and then get the nerve to slide through it.
So that importance there of, I guess, with cupping, creating that decompressive effect, you mentioned how nerves require a lot of blood and oxygen. So I guess giving it that little bit more blood flow, more nutrients, with movement, reducing the amount of load through there can have some really great benefits on it.
Yeah, and the benefits, Bo, which again, I don't understand this, but they can happen so quickly that the person can get up and go back to their star sign, which might be every time I go to put my sock on, I get enormous hip pain. And they can get up and try that. And the pain is sometimes completely gone. Not only that, you can then palpate over that tissue, which was sore to begin with, and it's not sore at all. I don't know how those sensory changes can be changed so quickly. Don't even pretend to understand it. But so be it. It can make huge changes. So what are we doing? We don't really know. We're just theorizing here, right? So if you just go the complete biomechanical model, we've got a nerve that's not sliding well. We use cupping, draw it up, move it around, pull, prod, poke, distract, whatever. Then all of a sudden, there we go. It's moving well. Nerves like to move. Great. That might be it. Or as you say, we've got the nerve and the capillaries running together. It might be the capillary that's actually compressed, not supplying the nerve with enough oxygen. The nerve gets cranky and you start to feel it as pain. Pain is there to tell us, hey, there's something not quite right. Could you make a change down there, please? And as a therapist, we we just allow that capillary to supply more blood. Don't know, but it's an option to consider.
Yeah, and it's great the way that's what we should all be doing when we do a technique is what is the actual mechanism? What are we actually achieving here? Like you said before, we might get an effect from treating QL, but is that why we got the response or is it something else? So I really like that reasoning there.
Yeah, and look, when we're young therapists, though, now that we're old and mature and incredibly experienced, we know everything. It is that classic example. As you get older and you learn more, you realize how much you don't know. It's been said 1,000 times, but I was taught in my schooling that all pain was due to trigger points. That's what I was taught. And that's what I did for the first couple of years of my career. I searched for trigger points, got results. I thought I knew what I was doing. But then the question came, as I've talked about before with you, Bo, is that why was there a trigger point in the first place? Or did I alleviate a trigger point and its associated taut band, which then had a kick-on effect to change a nerve's mobility?
Yeah.
So, I think to say this is what we're doing with this technique is silly. Doesn't mean we can't theorize and hypothesize and try to think, well, we're potentially doing this, this, and this.
Yeah.
I wouldn't go to that model, which I won't bring up now because it'd be unprofessional. But all manual therapy is crap because there's no evidence. Like, oh, that's silly. There's miles of evidence. We just don't know what we're changing. We're still getting really good clinical results. We're just not 100% sure of what we're actually doing. Science will eventually figure that out. But you and I might be pushing up daisies, mate. All right. So a couple of other examples of nerve stuff that people would have heard of, I think. The radial tunnel. So you can see how the radial nerve splits in a couple here, and the deeper portion runs straight through your supinator. Right? Now, if someone uses that supinator a lot, like especially in the old days when you actually had to use your hands penetrating, using a screwdriver, using that supination. So when you use a muscle a lot, it expands and grows, gorges with blood. It takes up space, which means there's less space for the nerve. Right? So in that scenario, you'll have a compression of the portion of the radial nerve through the radial tunnel supinator, through that radial tunnel supinator, right? So that's another example. I think I've got the classic example coming up.
And just on that, Brad, because I did that assignment for you when we were.
Oh, is that right?
Yes. But it's important to note that when with those types of compressions, that it's not always going to be the, as you said before, the pins and needles, the tingling sensory component, because there's a motor component that gets compressed there. And that's where it can be more that heaviness, loss of function, weakness that may present as, is it just a trigger point? We've got to explore the nerve, because that could be why there's not getting the appropriate innervation, or why it's not getting better through just treating extensors. So that's an interesting example there.
Yeah, to me, anytime someone presents with lateral elbow pain, you got some of the obvious ones where they've lifted 100 bricks for the first time in 10 years and ended up with a acute tendinopathy, tendonitis. But you still got to consider how much is the radial nerve. Considering the radial nerve has a fibrous attachment to the lateral elbow, it is right smack on that that combined attachment of the extensors. You've got to consider the nerve. And if the nerve's not involved initially, it might be 3 weeks later when that fibrous tissue gets laid down. And as we talked about before, shrinks from collagen 3 to collagen 1 and radial nerve gets caught in it. All right. You've got to consider the radial nerve for the all lateral elbow pain. Absolutely. And as a good example, what you just said before is that people go, on nerve pain, you get tingliness. Like, that's just not the case. Well, it is the case, but there's so many more pains. My father-in-law came to me one day and said, I'm walking down hills and I'm starting to fall over. What the bloody hell's going on? And I looked at his leg and thought, wow, his quad, and this is a very, very fit man. Put in perspective, he had 0 back pain. He had 0 pain anywhere, nothing. But he had massive quad wasting. And straight away I said, well, we have to go and investigate this. I'm a bit curious that you've got 0 back pain, 0 symptoms in your leg at all, but this perceived weakness. It wasn't perceived, it was actually a weakness. So when he cut a long story short, when his MRI, he had a massive disc bulge, a massive disc bulge at L3-4. So right smack on the femoral nerve component, because L2, 3, and 4 combined to make the femoral nerve. So his femoral nerve was so incapacitated that he had a massive atrophy, but it was all the motor component. The sensory component, he had all his sensory tests were all fine. So the sensory component was absolutely fine, but the motor component was in all sorts of pain. And again, the disc, although it was incredible bulge, the disc itself was still healthy, it was just bulged. So he had no back pain. So that's an example. I'm glad you brought that up, is that nerve pain can be all sorts of presenting signs and symptoms.
And he's a farmer, so he'd just be like, okay, I'll just put up with it. It's all good.
He did. He went, nothing to worry about. I'm like, well, he goes, good, I'm going. Off he went. And he probably did the right thing. He just used it over and over and over and over again until it, the disc bulge obviously receded and the nerves start to transmit as it should, and the muscles start to come back, and it's just all history now. So, often with nerves, people get told not to move, but you read all the latest literature, keep moving. You've got to keep moving.
That's a really, really good point, because again, there's so much fear, especially I guess when there is that dysfunction or the sensory changes, that the perception from the patient, they may feel like nerve means something serious. I'm going to need to have a wheelchair potentially. It's this, huge exaggeration, but the movement can be so beneficial as far as desensitization, providing it with more nutrients and oxygen. So I think that's a great takeaway there as well.
And the mechanical interface needs to be moved.
Yeah.
Yeah. And that's where, for me, if we understand this and we are the first point of call for that person, we can say, and if you're not confident, then refer them off. Absolutely do so. However, in between that, they see you and the referral person they get to see, that might be 5 days. Right. And they're going to be in all sorts of issues potentially, right? So what advice can you give that's well-known, gold standard? You can read it off the internet, you can Google this stuff. What does the gold standard do for acute disc bulge compressing a nerve? And it's there, you can list it. You don't have to tell them and think, oh my God, am I outside my scope here? You can print it off Google and saying, spine health suggests these are the best things to do, right? And it might be, whatever you do, don't lay on your back for too long because you won't be able to get up. Try not to sit too long because there's 200 to 300% more pressure on your lumbar spine, which will create further compression. Don't sit in a polylordotic position because of blah, blah, blah. So if you understand that, you've read it, you're confident with that information, it's come from a good source, then you can give that to that person saying, look, I can't help you at this stage, but this is what's recommended. So until you get to see this other person for some scans or potential treatment, and they treat them for a disc bulge, you can't do much. You tape it, you take some medication, you wait. You keep moving when you can, You can't go and have your disc pushed back in or whatever. So generally it's just wait that inflammatory period out and then try to adjust the mechanical interface and your indirect stuff like your posture and your habits while the recovery occurs. I'll go over a couple of other peripheral nerve stuff for people who are familiar with. The classic is obviously your median nerve as it runs through your carpal tunnel. Right. So carpal tunnel, probably most overdiagnosed thing you see when they go to GPs. GPs don't study this stuff. Well, some of them do, but most of them don't. So the minute they get any paresthesia in your hand, it's carpal tunnel. And it was only 3.5 weeks ago, I had someone present with, being told I've had carpal tunnel syndrome. I've heard you're not too bad with nerves. How can you help me? Show me your symptoms. Symptoms were here. So what nerve's that, Bo? Can you remember? Don't fail me now.
Nerve.
So we've got the ulnar nerve. It can't be carpal tunnel syndrome when the paresthesias are in the ulnar nerve distribution, right? So one, it's poorly diagnosed and probably overdiagnosed. And we know that the carpal tunnel is a group of tendons and bones and ligaments and so on where the median nerve traverses through. So you can get true carpal tunnel where that stenosis occurs, stenosis being the decreased area of a foramen minor or a tunnel, right? So it slowly compresses, and it might be with the excessive use of those tendons or inflammatory disease or whatever the case may be through this area. Yep. So that's one mechanical interface for the median nerve. One, right? So where's the next most likely mechanical interface where it can have an issue? Pronator teres. It runs right through your pronator teres. So if you've got an issue with your pronator teres, potentially it's contributing to this median nerve pain, right? Where's the next most likely mechanical interface? Well, it traverses up through this area underneath your bicep, and then it gets up in toward the more proximal areas. And there's not too much that can happen through here. In saying that, the next person will go, I found something. But there's not too much that happens through here. Then the mechanical interface through this area of your body from your neck down to your shoulder is very similar from one nerve to the next, right? So the median nerve comes there. So you've got the disc and facet joints associated with as the nerves pop out of the neck. Then you got then they combine for the plexus. The plexus goes through your scalenes medius and scalenes anterior, which is your scalenes triangle. If you've got an issue with your scalenes medius, scalenes anterior, then potentially you can be compressing on the component of the brachial plexus, which becomes your median nerve. Right? Then the next part, unless it's like thoracic outlet syndrome, you're like the 3 areas of thoracic outlet syndrome. Then you've got over top of your first rib, underneath your clavicle. All right. So if your first rib is sitting up, you're compressing on the base of your brachial plexus. Third area is underneath the coracoid process, 3 layers of fascia, pec minor, and so on. So if any of these 3 areas have something going on, which is compressing that brachial plexus, they could be contributing to your median nerve pain. Now, you could talk about these 3 areas for a day. So this area of your mechanical interface, if you understand it runs through it, then it brings a whole heap of treatment strategies and options for you. But if you don't know this basic anatomy and someone's got median nerve pain, you'll panic and throw the person away, when we potentially have the best treatment options that person has with our soft tissue skills. You want to depreciate the potential of scalene's anterior and medius. We've got great hand skills to do that. You want to make changes to pec minor and associated fascia. We've got great hand skills to do that. All right, again, we're treating the mechanical interface, not the nerve. All right, because the nerve often in the peripheral system is not the issue, it's the mechanical interface that's creating it. So again, having that understanding of when someone says they've got carpal tunnel syndrome, is the problem there? The problem can be anywhere along the line of the median nerve. Knowing where it runs and the mechanical interface, the most likely areas to cause problems, you straight away got a whole bunch of potential options to treat. And then you can give them some basic stretches to that mechanical interface to complement your work or tennis ball work or whatever you'd like to do. And then some basic just mobility stuff for the nerve, just some really basic stuff. And again, if you're not confident, you can refer off. Right? So that's a classic example of understanding the anatomy of a particular nerve, the mechanical interface, and what we can potentially do for it. Right? I'll leave the tension points apart at this stage because it gets a little bit technical. I remember looking at your face when I was teaching you and you went off and thought about dinner. All right. So going just over the pathology, there's a compression, tension, and adherence. And again, I'll send you this PowerPoint so people can read over them. So they're the main ways in the peripheral nervous system that we can help treat someone when we can see these things, acknowledge, subjectively assess, and objectively assess for them. As I was just talking about before, there's vulnerable sites, right? So for the median nerve, it's through 1, 2, and 3 sites. Pronator teres, carpal tunnel. They're the main sites that, as you can see depicted here, where that median nerve is running through the carpal tunnel. So each nerve has more vulnerable sites. Radial nerve to the radial tunnel, as an example, right? And where are those vulnerable sites? They're listed here. Tunnels, where a nerve branches. And like example of where a nerve branches, you've got sciatic nerve, and it will branch or bifurcate. It will branch about 4 to 8 centimeters above the popliteal fossa. And it splits into 2, becomes your common peroneal nerve and your tibial nerve. So where it splits, it means it's not as mobile. So when you're doing a hamstring stretch and you think, wow, what does that pain in the back of my knee? It's going to be your sciatic nerve, not your hamstring. Right? And a lot of people just don't understand that. They think that their range of motion is limited by muscle and fascia. Your range of motion is predominantly limited by nerves. And we can easily show that. Not now, but we can easily show that. In your nervous system, I'll quickly mention it. C6, actually I will mention it because it's good for whiplash. So there's areas in your central nervous system. So your spinal cord just doesn't run inside the bones. It's actually got all these ligaments attached to the bones called denticulate ligaments. There's a couple of others as well. So it holds it steady, right, within your spinal column. But particular areas, C6, T4 to T6, L4, they're much thicker. And even around T12, they're much thicker. So the ligaments that hold the spinal cord within the spinal canal are thicker, right? Why? C6 is the middle of your brachial plexus. L4 is the middle of your lumbar plexus. T4 to T6 is the apex, because there's no plexus in your thoracic spine, remember? T4 to T6 is the apex of your thoracic spine usually. So at the apex, they create an extra bit of tissue to try and hold your spinal cord still, if you like, or protect it. So when you go through big flexion and extension moments, then instead of the nerve being pulled and tethered, is that the load gets distributed through the denticulate ligaments. Got it? Brilliant, easy. 100-page anatomy in 2 minutes. Now, when you go whiplash, when you go whoompa, so you get hit from behind. What's important about a whiplash, when you don't know it's coming, you don't brace. When you don't brace, you don't use your myofascial system to protect you, right? So that's where with big whiplash, you don't tend to have muscle injuries. You end up with fascial injuries. And what a lot of people complain for at 3 weeks, all right, collagen 3 to collagen 1, they start to get pain where? C6, T6, sometimes T12, because it's that universal joint area, and L4. So now when you see that, you don't have to go, I wonder why, because the anatomy tells us why, is that area went through a massive insult and protected your spinal cord by those denticulate ligaments taking all that load and potentially being damaged. Right, so that's what a tension point is. Okay, so throw that one in because it's important for the whiplash scenario.
That's really great, Brad. Hey, emphasizing understanding anatomy, because these are your vulnerable sites, but that doesn't mean that they're the only spot that it gets compressed. That's going to come back to mechanism of injury and their history and their aggravating factors. But again, you've spoken about knowing that mechanical interface, treating the mechanical interface of the nerve, and you can get a great response, and then add in your mobility from there.
Yeah. And we've already gotten bulk the knowledge. We just have to put together. Right? You think about your scalenes anterior, posterior, medius, is that they're upper respiratory accessory muscles, right? So hence, if we stand up tall and allow space for our diaphragm to be used during the breathing process, then we'll take in the bulk of our oxygen, air, through the lower portion of our lungs, right? But if we're in a poor posture, where our diaphragm is basically sitting on top of our liver and our stomach, it can't lower. So we just can't take in that volume of air. So hence those people have to start to upper respiratory accessory breathe, which happens with your scalene. So your scalenes start to lift, all right? They lift the first and second rib to create a bit of space to breathe, right? So think about that scenario, someone that's got a really poor posture, potentially a rotation, so they might be using one scalene more than the other, left versus right. The more a muscle gets used, the more it hypertrophies. So when a muscle hypertrophies, it takes up space. So when it takes up space and there's a whole nerve complex running through it, then there's a potential for it to compress on that portion of the brachial plexus. If you look up thoracic outlet syndrome, that's, I don't know why it's called a syndrome anymore, because we know what causes it. I think I've talked to you about that before. It's a stupid word, stupid use of the term syndrome. So if you think about that scenario, someone comes in with some type of nerve complaint down their arm, and you could potentially attribute it back to the fact this person got terrible posture, upper respiratory breathe, scalenes hypertrophy taking up space, compressing on that nerve, they're getting tingling into their hand. So all of a sudden you think, oh, that's far-fetched, but when you understand the anatomy and how that anatomy is supposed to function, all of a sudden that becomes an absolute reality. And you think, wow, so the way I'm going to get rid of this person's paresthesia in their fingers is to get them to sit up tall and teach them how to diaphragmatically breathe. So again, understanding the anatomy of the nerve, the mechanical interface, and understanding what that mechanical interface does and the potential for it to have some type of implication to the nerve, well, your treatment protocols just, wow, the options open right up. So, I mean, I know at our clinic, we make sure people consider that. And we get a lot of people that go through a breathing education program. We've got a couple of people that are much better than me at I like to refer to, but I'll give them the basics. And if that doesn't help, I'll refer for someone that's much better than me. But again, that's just a classic example of understanding the anatomy and the function of the anatomy and having the nerve secondarily gets affected and end up with symptoms in the, say, the hand.
Yeah, they're a really interesting one. They might spend, when in Canberra, when you've got such a big population of public servants doing this all day, and then they decide to do some spring cleaning or some overhead work, and then all of a sudden they've got these neurological symptoms. But based on that anatomy going underneath that coracoid process, you can see how just understanding that mechanical interface can really be attributed to those symptoms.
Yeah, absolutely. And then understanding what you just said then means that you can then give some really good advice. I suggest you don't do this a whole lot in the next few days and let your nervous system calm down. Don't sleep like that. It's really going to upset your nervous system, right? So just have the basic understanding of how that nervous system works. You can give some really good advice for that person so that they're going to not increase their symptoms. They're going to help.
When you say it like that, Brad, it just sounds so simple. Nerves aren't that scary.
Yeah, it all seems very simple when you've stared at 1,000 papers and done it for decades. I still think, for me, I love this stuff. I love the nerves stuff. It's a huge topic. Trying to reduce it to a knowledge base which you can be just slightly competent in. I think that's the important part. And this is what I think the bit that I'm trying to get across today is the area that we can have quite a significant role with any presenting patient with these types of symptoms. Bo, lead me here. Should I talk about a couple other basic nerve issues?
Yeah.
So a couple of your arm, you got 4 main nerves that run down your arm. 4, right? 4 of them get to the elbow. It's got your ulnar and your median nerve. Got your radial nerve. Then you got your musculocutaneous nerve. At the wrist, we only got 3 make it to the wrist. If you make a gun, that's your ulnar. That's your radial nerve. That's your medial nerve. Now, it's a little bit rudimentary. It's a little bit more specific than that. But as a start, it's a great way to look at it. Ulnar, radial, median. All right. So you've only got 4 nerves. These little nerves that come off them, but those 4 major nerves, if you learn them, you're well on the way to understanding your whole arm. The mechanical interface for each, not too bad. It's not that difficult. Mechanical interface through this area, it's pretty much the same. Right, so it's not too difficult to learn. Then you've got little nerves that pop off portions of your brachial plexus. And for instance, this one here, which is suprascapular nerve. So superscapular nerve, you think of the myotome meaning muscle pattern. So it means what muscles does that nerve innervate? So if you have a look at your suprascapular nerve, it only innervates 2 muscles, your supraspinatus and your infraspinatus. So if you see someone with an infraspinatus, which is severely atrophied, rather than panicking, you can go, hold on, what nerve innervates that? Suprascapular nerve, right. Where is the most likely areas for that nerve to be impinged? These 2 areas right here, right? You got your supraglenoid notch and supraspinous notch. So therefore you can narrow it down and think, well, so you got potential irritation through one of those 2 areas. Why? And that is a really good question. Like, why do those areas become irritated? Why does biceps femoris have a trigger point? Don't just treat it, but try to understand why. So why do these areas become compromised? So if you understand how a scapula works and how the nerve fits within that movement, then you can start to see a pattern. So suprascapular nerve injuries, well, you can have it from a compression injury. Let's say I had a guy a few weeks ago, he had a skiing accident and he landed on his shoulder. So he didn't do any bony damage, but he's got a large amount of swelling through the suprascapular notch. So he's getting atrophy and weakness through his infraspinatus, so he can't externally rotate. Right? So you can have it like that. But generally they happen without any known incidents. So if you think of backstroker, so someone who goes through this motion, right? So in this motion, the area that this suprascapular nerve traverses through is compromised. There's reduced area, right? Generally what should happen is that our elbow and shoulders sort of always remain about the same height. The moment you go above it, you're starting to get compression. Okay, and you think, well, there's plenty of movements that we do when we go above it. But when we look at like a tennis player, for example, when a tennis serve, you think, wow, they're going to have miles of compression, but they generally don't, because if you look at a tennis player, their shoulder, and elbow generally stay in the same line. It's just that they move their body and then finish it off. All right, so for a tennis player that stays in this position, generally okay. But there's a couple of sports that can't do that, like backstroke. So their elbow becomes higher than their shoulders, right? Then you got volleyball. With volleyball, because you've got a net there, you can't do this sort of thing because you're going to hit the net. So they stand up tall and do this. So you've got shoulder, shoulder, and elbow higher. So these guys can get suprascapular nerve compression. But again, if you understand the anatomy, the biomechanics of it, you think this person could potentially have a suprascapular nerve palsy because of the work they do, the sport they play. Well, that's a classic nerve. Long thoracic nerve.
I think just on that one, sorry, if I could interrupt. Do you see that often misdiagnosed as rotator cuff tears or rotator cuff pathologies?
Yeah, if you look through all the literature, you'll see that all the time. So there's some of the differential diagnosis to a rotator cuff injury is a suprascapular nerve palsy. Mm. So if it goes to a sports doc or a sports physician that instead of a GP, so poor old GPs can't know all this sort of stuff, but sports docs and sports physicians, this is what they train in, musculoskeletal injuries. So if it goes to one of them, they probably won't miss it. But they'll at least entertain the concept that it could be. Whereas a GP might miss and go, you've got a rotator cuff injury. So absolutely. If you've got a rotator cuff injury, you still have generally some massive tissue through here. With a nerve palsy, it'll decrease, it'll atrophy to the point where it only looks like this bone. So I think that's probably like a visual differential diagnosis, if you like.
And do you see sensitization of this nerve as a secondary response?
No, this is the thing. When you're with this type of palsy, you don't get any pain at all. Mm-hmm. Not that I have to be careful saying that, but from my understanding, no. And I've seen plenty of people with this because of my background working with sport, with say backstrokers and so on and volleyballs. They don't get any pain. They get secondary pain because when the supraspinatus and infraspinatus don't have an input into shoulder mechanics, then you start to get secondary shoulder mechanic issues. So they generally present by saying, starting to get shoulder pain, and it might be some type of impingement pain or whatever the case, but it's secondary to the fact that they've got an infraspinatus and supraspinatus that is not contributing to the mechanics. Does that make sense?
Yeah.
And what was the other point with that? No, I forgot.
Because I think it's just such an interesting area where, someone sees poor shoulder function, rotator cuff tear. So having that understanding as a differential is really, really key to consider. And that was some great examples with, different athletic populations.
Yeah, again, you've got to understand your population, right? If you understand who you're treating, and again, I've been involved with sport. So when you're in sport, you have to understand the mechanics of that sport. Otherwise, you are not going to contribute as well as what you should. So when you spend 20 years just focusing on function, biomechanics, you get to know a lot of the areas of the body really well. So it holds you in good stead when you deal with the general population.
Do you see it much in the general pop other than a trauma-related fall, as you said before?
Only for people who do things like go swimming 3 times a week for a break and that sort of stuff. So this one probably not so much. But you've got, that's a suprascapular nerve. The nerve that looks after your deltoid is the axillary nerve, which comes off the top of your brachial plexus. When you shrug your shoulders, we upper trap, that's the accessory nerve. So when you go through like a nerve test, you often do all these tests to make sure those muscles are working, and then it can be attributed back. If it's not working, be attributed back to a spinal nerve or a peripheral nerve. The long thoracic nerve, I think most people would have an understanding to a degree, because if we have a long thoracic nerve palsy, what's the muscle that it has a motor input into, Bo?
Serratus anterior.
Ooh, I was going to send you a file. So if we've got a long thoracic nerve palsy, then we're going to have what with the shoulder?
Significant winging.
So when people go, I got significant winging, and they try to attribute it to something other than nerve, I say, be careful. You've got to consider, there's no use giving a whole heap of retraction exercises if a long thoracic nerve is not addressed, because it just won't happen. You need to go through that motion, absolutely. However, you need to address the nerve component to that. And often these people again won't have any pain, it'll be secondary. Right? So there's some of the upper limb nerves, like the main four, but then some other nerves that come off the brachial plexus that you might want to be at least aware of.
What are some key mechanism of injury for the long thoracic nerve?
Again, these overhead type movements.
Overhead work.
That's the main one that I've seen over the years. And again, backstrokers, I've seen a couple of backstrokers for that. And there's a lot of injuries that occurs, generally the compression on the extreme tension, like someone who's a skiing accident where their arm gets ripped back and they tear a portion of the brachial plexus, or motorbike accidents, that sort of stuff. Mm-hmm. All right, some of them, a lot of nerve conditions just have no mechanism whatsoever.
Yeah, right.
No one understands why. It's really difficult, especially when you get into the brachial neuritis and a lot of the other, where the actual nerve itself is the pathology rather than mechanical interface. They often come on for no reason. A lot of people get mixed up with anxiety. With anxiety, you get all sorts of neurological symptoms and you think, oh my God, I'm going to die. And then you have a couple of wines and realize they all go away, or your football team wins and yay, my nerve's gone. So it can get tricky because there is numerous things that can cause nerve pain. But again, if you understand what each one is and then try to understand your patient, thinking, are they an anxious patient? Yes, they are. Well, their signs are going to be exacerbated because of that psychomotor component contribution to, what they're probably feeling mechanically.
Right.
What else we've got? All right. So I know it's getting a bit long. You're going to have a lot of information here, Bo. I have to make
good.
Section 1, 2, and 3. Wow. So when someone comes in, what do you look for? So the dermatonal cutaneous myotomal patterns, that is so important. I'm going to flick through to this page. That's the I think most clinics have got this on their walls. Mm. But when I've taught this around the country, I always ask, what is this? And most people go, it's pretty. They don't really know. So this is such an important poster to have, really important, but gee, you've got to know what it is. So you see these patterns on, can you see my arrow there, Bo?
Yeah.
So you see this side is attributed to nerve root compression, which means the pathology is within the central nervous system. It's around that nerve root, so disc or facet joint or foraminal compression. Right? This side is all peripheral nerve irritation and compression. So this side, damage, irritation, compromise within the central nervous system, this side in the peripheral nervous system. I'd argue that this one here, the peripheral nerve, is the one that we can have the greatest effect on, right? This one, we're probably giving advice and referral, or if you've been around long enough and have a good knowledge of it, you can help a lot with direct and indirect type treatment, like postures and recommendations, all right? But always be careful with your recommendations, obviously. So this, and obviously this is just the front of the body and the back of the body. So someone can pop up and see that there, that's my pain. That's what I get. And you think, oh, wow, all right, that's S2. So they've got an S2 nerve root irritation. Okay, so it's central. So what can I do to have an impact on that? Right, and that's another whole lecture. Or someone might go, actually, that's my pain right there. Wow, okay, so they've got a common perineal irritation, common perineal nerve irritation. Right, so again, if you understand the common perineal nerve, where it runs, what a mechanical interface is, you can start to treat that mechanical interface to have an effect. Right, so if someone presents with symptoms through one of these patterns, then it gives you an idea of where you can treat and what your options are. All right, so I'll go back up. So that's this term. So dermatonal cutaneous nerve distributions and myotomal patterns are like we just talked about before. Infraspinatus is wasted or atrophied. Hold on, what is it called? Superscapular nerve. So that's the myotomal stuff. The vulnerable areas, like we talked about before, where is a particular nerve more vulnerable? Pronator teres, through your carpal tunnel. So you know where particular areas are in the body that are more vulnerable than others. with your whiplash, C6, T6, T12, L4. Right, you know them. They're more vulnerable. Right. Lines of pain and clumps of pain. So if someone comes in and says, I know what's going on, I've got this pain that runs all the way down here. The only thing they're drawing is the median nerve. So they've told you, oh, wow, this is a median nerve condition. All right, now I've got to try and find out what is happening with the median nerve. What mechanical interface, what's happened for this median nerve to be irritated? And then your treatment options will vary according to your subjective and objective assessment. Atrophy is wasting, like we talked about just before. Weakness can come from a lot of things, but you have to consider a nerve, right? Obviously. Paresthesia is those weird-ass pains, tingly. It can be little jabbing pains on your finger. It can be numbness. It can be all sorts of stuff. It can mimic joint pain. It can have an ache-3 eminence, all right? All that stuff, you must consider some type of nerve component, paresthesia, right? Anesthesia is numbness, which is pretty obviously a nerve component of some description. We'll leave double crush. It gets a bit difficult. If it's bilateral, if people say, I got symptoms in both hands, so it's centrally driven, which means there's something going on with the central nervous system to drive it bilaterally. So one, you think, well, that's at least an orange flag. You might want to refer that off and get them to check it out because it could be anything within the central nervous system. But what I'd say is, are you stressed? Are you anxious, Bo? Look at me, Bo. Are you anxious? I know you are, because you have truck drivers that are driving into Western Australia and they're making you panic, and I can see you're starting to sweat, Bo.
The next 14 days will be on
up, Bo. All right. Could you imagine Gil McLaughlin when he found out yesterday morning that a truck driver got tested positive in Western Australia? And the AFL community, Gil McLaughlin had tingles everywhere, thinking, holy smoke, I'm going to die. It's just anxiety. Right? So consider bilateral symptoms centrally driven. That's an orange flag or a red flag if it's with some other symptoms. But it's most likely autonomic with most cases, or anxiety. Sweaty hands, feet, nausea, headaches, autonomic type symptoms. Yeah. Myotomes was just asked before. You have a look at that. Now, that's one hell of a myotome. The suprascapular nerve is easy. It's got 2 muscles. Long thoracic nerve, pretty easy. It's got 1 muscle. Then you got this. So sciatic nerve, although it splits into a couple of different nerves, that's a big myotome. So it becomes difficult to identify what portion of the sciatic nerve is potentially damaged, but it's a large myotome. All right, some of the nasty stuff that you have to be aware of. I'll say this with any nerve condition that you're treating. If you've identified, you think, I really think this is a nerve compression of the median nerve through your pronator teres, let's say. You've got to consider time to irritate, severity, and longevity. Remember I said if anyone got this wrong in the class, I'd automatically fail them?
Never forgot it.
People still got it wrong. What does this mean? What does this mean? And it's so important, especially with nerves, with any condition, but especially nerves. Time to irritate. I'll give you 2 examples. One, I was out in the garden for 4 hours gardening, started to get a little bit of back pain. It didn't really stop me. But then I got a little bit into my calf, which was a bit weird. So I had a rest and it went away in 10 minutes. Versus, I was in the garden, within 5 minutes, my back was killing me. Then I had really searing calf pain to the point where I couldn't hardly walk. Went inside, I was sore for 2 days, and eventually came good. So 2 examples: time to irritate, short, long. Severity, I can walk, I can't walk. Longevity, went away in 10 minutes, went away in 2 days. Right? You've got time to irritate short, severity is large, longevity is long. Then you have to be really careful with your assessment and treatment. Really careful. Because if you take someone through an upper limb tension test when these 3 things are high, you just make it worse. If you treat them aggressively, you're just going to make it worse. Right? The lower those things are, you can be more aggressive with your assessment, more aggressive with your treatment. Unfortunately, it's an intuitive thing. You'll all make mistakes, unfortunately. So better on the side of caution. And you think, well, someone's already complaining of nerve pain through this area, which can be C8, but also can be ulnar nerve. And you think, no, this is classic ulnar nerve because I'm looking at the map, it's perfect description, but it's killing them. Don't put them through an ulnar nerve test. You already know what's going on. You don't need this subjective assessment to suggest otherwise, because the objective assessment is almost unnecessary. Like a lot of senior therapists in all sorts of professions, the amount of assessment to do objectively gets less with time because they've done it over and over again, and what they see subjectively is produced in the objective test. You often use the objective test for the patients so they can see some change in your clinical treatment more than for yourself, right? So that's really important, irritability. Right? Some of the orange flags, red flags, shaky gait. Someone's got a shaky gait, comes in and can't control their leg, right? And I've seen it a few times, scared the crap out of me. You know, I referred them off, and we've had 3 or 4 people with MS and a couple other people with some other neurological conditions going on. So if someone's got shaky gait, get them off. Someone's got spasticity, get them off. Refer them off. Don't panic and carry on, because that's obviously going to make it worse, but just suggest that you want to count out some red flags, go and see your GP as quick as you can. Problem with bowel movements, right? Patterns of paralysis, all that sort of stuff, generalized electric shock, all those things. When a patient presents, you know there's something pretty nasty going on, potentially with the nervous system, you want to get them off, right? So make sure you've got someone ready to send. Get in your local community, find a sports physician that's got good knowledge and happy to take those referrals if you get them, right? Diabetes, diabetes have a lot of peripheral capillary issues. And when you've got capillary issues, you're going to have nervous issues because they demand high oxygen levels. Yeah. Objective assessments. So these are the things that we use to prove or deny our suspicion that a nerve's involved. Same as any test. That's why you do these objective tests. I think it's this. Let me test for it. Yes, I'm right. No, I'm wrong. Right. The nerve tensor test, we won't go through now, obviously, but nerve tensor test in the upper arm, you've got upper limb tensor test 1, which is generally for the brachial plexus. I can't do them on this little small screen bar. I've got a big head. But you've got upper limb tensor test 1, 2A, which is for the median nerve, 2B for the radial nerve, and 3 for the ulnar nerve. And what they do is they bias or isolate that nerve so you can test it individually to the others. With your lower legs, you've got your straight leg raise, which is for your sciatic nerve, and the branches of the sciatic nerve, which is your sural nerve, your common peroneal nerve, and your tibial nerve, just those 3. And you've got other tests for your femoral nerve and your rotator nerve. All right. So again, you can go learn those in a course or jump online and follow them, so at least you understand them. So again, the important part is that those tests are to confirm or deny your subjective assessment. Does that make sense?
Yeah, definitely. That can show that nerve's sensitized or sensitive to pressure or movements. They're fantastic tests.
Yeah, and what they also do when you know them well is they start to tell you where the irritation or compromise is most likely occurring. Right, but we can't do that now. We talked about when to refer. And what is the treatment? I'd say indirect and direct treatment. Indirect is, all right, I've got a median nerve issue going on, and they've got this terrible posture. They're not diaphragmatically breathing. Scalenes are going crazy. First ribs up here, blah, blah, blah. Get them up, teach them how to diaphragmatically breathe. That's an indirect treatment, if you like. Direct treatment is to mechanical interface directly. Right? So again, as we talk about, if you understand where the mechanical interface, we can treat it. We've got great hand skills to do that. All sorts of stuff. Cupping, dry needling, whatever tickles your fancy. As long as you know what you're trying to achieve. Then the indirect stuff, you have to understand the body a bit better. Obviously, if you don't understand how your scalenes anterior, medius, posterior raise the first 2 ribs, create space for the lungs to expand when someone's not using their diaphragm well, then you need to bone up on that sort of stuff. You need to have an understanding of those sorts of movement patterns within the body. All right, and then the home exercises. Generally, we give home exercises to the mechanical interface, not the nerve itself. Yeah, so if you're trying to increase the range of motion of the pec minor, then treat. Give them maybe a self-treatment thing to do at home, and then a stretch that complements that. All right. If you're not confident with the nerve mobility stuff, don't do it. Just treat the mechanical interface. That's often enough. Yeah. Hey, I usually got a picture of my stupid head with one of my kids or something, but
that's fantastic.
Right? It's a long session. I hope it wasn't too long.
Yeah, no, that's great. And I think just to summarize on that, we've got your central based problems, which we might present in a dermatomal distribution.
Yep.
Then you've got your peripheral compressions, which might be just an area, a region, which could be compression from at the mechanical interface. It just compresses a portion of that nerve.
Yeah, compression, tension, or adhesion. Yeah.
Yeah, and that's comes back to the history. If we spend a lot of time going through that history and identifying how it started, because if it was a mechanism where they've been doing a lot of twisting, or they've tore their hamstring and now they've got this residual pain in the back of their leg, that could be an adhesion or a tethering, as you mentioned.
Spot on, mate. Is that from their history, they generally tell you what's going on. If you listen well, if you know what to listen for. For instance, we used to treat the walkers, and because they had to try and keep one leg on the ground any one given time, they have a massive Trendelenburg gait. So when you've got a massive Trendelenburg gait, your sciatic nerve pops out a sciatic notch and then goes around your ischial tuberosity, right? So the more you go into that Trendelenburg gait, the greater the fulcrum around for the sciatic nerve around that ischial tuberosity. So it rubs and rubs and rubs and rubs and rubs. So if someone comes in and they've got a massive Trendelenburg gait, or they're a walker, then straight away you should be thinking, I wonder what the health is of the issue of their sciatic nerve lateral to the ischial tuberosity. So they generally tell you what the issue is within their history taking, if you know what to listen for.
Yeah, and then so I guess in your physical assessment, you'd confirm that with straight leg raise, add in some adduction to recreate those symptoms. So that was really good, Brad, where, you mentioned that a lot of it's about that history, ruling out your red flags, understanding the mechanism, know your anatomy, where that nerve runs through. You can treat that mechanical interface, get them moving, and massage can have a fantastic effect, not only on the mechanical interface, but also on the central nervous system, lowering the volume of the threat signals.
Absolutely huge, mate. Don't underestimate. I used to be such a country bogan, like stupid autonomic nervous system. That's just for weak people. I'm like, oh man. Then I got older and thought, oh, I've got one of those things as well. And I saw so many psychomotor patients and just autonomic signs all over the place, until I had to think, hold on, this is really important to know. Actually, it's really important to know. It's ridiculous to deny it. And just to calm a nervous system down. Some of the stuff we've done over the years is just to put your hand on someone's sacrum and just rock their whole body from their sacrum. And they'll get up and say, I cannot believe what you just did. That was the most ridiculous treatment you've ever done. How come I feel so much better? How come I don't have that nerve pain as much as what I had? Because you potentially have just calmed down, taken away some of that excessive cortisol level, as we know from all the research. And that's been the component which was probably tipped them over the edge. So yeah, there's miles of different ways to affect the nervous system. It's, as you're talking about just then, it's just trying to understand what you can do to contribute to an overall treatment protocol.
That's excellent. Brad, thank you so much. There's so much valuable information there. We really appreciate your time. So thank you once again.
Excellent. Go the D's.